Welcome to this ABC webcast on telehealth and more, optimizing the practice of cardiovascular medicine in the COVID-19 era. This ABC webcast from the Association of Black Cardiologists will investigate emerging concepts to optimize care for patients during this COVID-19 pandemic. We should also note that these are times in which social justice is very important, and this is live at the time of our final goodbyes to the great John Lewis, who is passed on. And we use this as an opportunity to recognize the legacy of the struggles of those who have gone before us. I'm Dr. Keith C. Ferdinand, the Gerald S. Berenson Endowed Chair in Preventive Cardiology at the Tulane University School of Medicine in New Orleans, Louisiana. And we have an esteemed panel of leading investigators and scientists in the field of cardiovascular medicine. In no order other than the order of presentation, we first have Dr. Barbara Hutchison, MD, PhD. She is a past president of the Association of Black Cardiologists and a managing partner in Chesapeake Cardiac Care. Dr. Hutchison has a PhD in cardiovascular pharmacology from the great Howard University. She's one of the leading women in cardiovascular medicine and has been received as such in the Maryland and national auspices. She gives back to her students in the way of mentoring and has led the Association of Black Cardiologists and leads us now in this particular discussion. She'll come after I give a short presentation. Next, we have Marisa Haynes Md Mph. She is the ABC Fellow representative to the board of directors. She is a star in her own right. She has a BS in molecular and cellular biology from Yale University and has gone on to get an MPH from Harvard School of Public Health and is now a cardiology fellow at the University of Pennsylvania. And we talked about social justice. She has led efforts in social justice at Yale as a co-president of the NAACP and has volunteered by being an attending at a hospital in Haiti and other things. And finally, the great Elizabeth O'Feely, Chief Medical Officer, Morehouse Choice ACO. She is now the chair of the ABC board, but she is also a past president. Dr. O'Feely is known nationally and internationally for her work in the field of cardiovascular medicine and women's health. She is also the Chief Science Officer of AccuHealth Technologies, empowering patient-centered care through technology and health coaching. Her awards are many, and she is presently one of the chairs of the National Academy of Science and a founding member of Anako House. Dr. O'Feely will give the last presentation, and I will give the first. Let's proceed. So one of the first things that we're going to discuss is an overview of the use of telehealth in terms of treating and caring for our patients in this present time. This particular presentation will be short. It will somewhat set the table for some of the more detailed presentations which will follow. This is not a model. This is a real patient. He allows me to use his picture, and it shows me in my clinic sitting face-to-face, talking to him using culturally appropriate, literacy appropriate language about his cardiovascular care. Science and art of medicine is the hallmark of which is direct inpatient patient care. But we know because of the difficulties with the infectious agent coronavirus that leads to the disease COVID-19, we have not been able to have outpatient care at the same level that we've had in the past. And there's been a great influx of patients who are using telehealth or telemedicine as their primary source of care. Now, why are we as cardiologists concerned with this? Well, we're concerned with anything that causes death and disability, but especially looking at the disparate amounts of infections and mortality in the African American, Hispanic, and other minority communities. We clearly are concerned about the impact of COVID-19 on our patients and the public health. And also because we as cardiologists now recognize that although it is named as a respiratory condition, it also affects the heart and cardiovascular system. So let me start with some ideas that I've had related to how we can utilize COVID-19 going forward. This table is from an editorial that I wrote along with my colleague Samar Nassar from George Washington on COVID-19. And we gave some practical solutions on what we can do going forward. Now, I'm not going to read them all, but they include, of course, hand washing, social distancing, and wearing a mask, having appropriate protection for our so-called essential workers, helping disadvantaged populations get access to early testing, contact, and isolation. I put a box around the things that are directly related to our discussion today. We also suggested a team approach using blood pressure monitoring, cardiovascular medicine monitoring, home scales, dietary consultations, and helping our patients to continue to control their cardiovascular risk. And we also were concerned that patients who were having symptoms, unstable angina, uncontrolled blood pressure, symptoms of heart failure deterioration, were not seeking care in an inpatient setting. And perhaps going forward, patients who have been infected with COVID-19 can use thermometers and pulse oximeters to better define when they may need to seek inpatient care. So remote monitoring is here. COVID-19 has caused a great increase of our interest in use of this. Now we're using some terms here, telemedicine, telehealth. The definitions vary. There are telehealth, which is generally more broadly any sort of monitoring or caring for patients, where telemedicine is narrowly defined to include technologies like live video conferencing and remote patient monitoring. And if you look at telehealth, it could be anything from text messages, emails, or any sort of telecommunication with our patients. And this includes some sophisticated online portals. Dr. Ophelia is going to show you how that has developed, and also simple communications with our patients. Now, I mentioned earlier that this is widespread. I personally still see patients, but the bulk of what I'm doing now in outpatient care is through telemedicine. Last year, less than 5% of cardiovascular care utilized telemedicine. Now it's clearly over 75%. And I think telemedicine is here to stay. We'll see some of the techniques that may be beneficial going forward. We also will look at some of the potential pitfalls. Next slide. So what's happening now with the as cardiovascular specialists? Many of us have gone from near zero to now 75% or greater of our care. And with this latest uptake in coronavirus infections, especially through the Sun Belt, including Louisiana, where I'm located right now, many places have even started to shutter their elective cases. It's affected the private practitioner, since patients are often afraid to come out of their homes in order to seek care. And it's led to us to use telehealth as a way of giving much needed care to our patients. The industry, therefore, has had to actually reinvent itself during this particular pandemic. Okay, here are some key problems that we have in terms of reimbursement, especially in the Medicare services. Presently, many of our patients are unable to use the smartphone with internet connection because of various reasons, and Dr. Haynes will discuss some of those barriers going forward, but they have allowed the reimbursement at the same level for telephone consultations, even without the use of internet connections. It's unclear exactly how long that's going to maintain, where they will allow just telephone calls. And we now know that some services that use audio only contact with patients probably will eliminate this service at some time in the near future. But there are real benefits. For we as providers, it reduces and almost eliminates no-shows since the patient remains at home. It may improve adherence, especially if we're giving 90-day supplies or even greater for medications. It actually increases our clinic capacity because we can now have an unlimited amount of patients that we need to see during a day's time, and it allows us to have flexibility as physicians. Patients like the convenience. They may actually have improved education since there's a one-to-one relationship during many of these telehealth visits, especially using the internet or smartphone. And it may actually decrease their time. There's no travel, sitting in a waiting room, waiting for the intake so that they can have a relationship with their physician, so there may actually be improved access. In terms of smartphone applications, there are a ton of tools, and this is not necessarily to show any one particular type. You have various forms of blood pressures, electronic scales with Bluetooth. You have watches that monitor pulse and arrhythmias. You can even have pulse oximeters that patients use, and certain forms of glucose monitoring now also can be Bluetooth back to the physician so that they can have an evaluation. I am a hypertension specialist, and I'm interested in the continued use of self-measured blood pressure. The American Heart Association, along with the EMA, released just this year a policy statement that suggested that self-measured blood pressure is an important component of blood pressure care. And I bring to your attention a new website called validatebp.org. And it shows various devices. They actually have pictures and names of the devices that have been validated by an independent scientific panel. Now, they don't recommend the wrist or the finger devices because there are some barriers in terms of making sure that they're utilized accurately at this point, but going forward, they may be included in the validatebp.org site. At the present time, however, it's only certain members of the upper arm measurement type of devices that are utilized. So where are we now with telehealth? Well, I think we're going to continue to use it. It's improved care by allowing patients to remain at home, especially during a pandemic. We need to make sure that the billing and reimbursement stays at a level which allows it to maintain the doctor-patient relationship. We can use it as a form of doing face-to-face education. And I've even suggested that in the future, we may want to loan or gift blood pressure devices and other devices to patients so that the telemedicine visit can be done at a higher level. So I thank you for that opportunity. We're not going to do Q&A behind each presentation, and we're going to move on to the next presentation, and that will be by Dr. Marisa Haynes. Dr. Haynes, feel free. Thank you.
Okay, thank you very much. Thank you, Dr. Ferdinand, for that introduction. I will be discussing the barriers to telemedicine, and my hope is that together we can discuss how we can overcome some of these barriers. So first, I would like to just provide some definitions. Dr. Ferdinand gave some definitions, and for the purpose of this talk, I found 3 definitions that help me conceptualize these terms a little bit better. So when speaking about digital health, which is the broadest definition, as you can see in this figure, within digital health, you have telehealth and telemedicine. So broadly speaking, digital health refers to the ability to transfer data and information using technology to facilitate the monitoring of health outside of the patient and physician encounter. An example of digital health would include wearable devices, such as smartwatches, for example, where patients are able to monitor their clinical measurements. Within each of these terms, you have synchronous and asynchronous interactions as well. So for example, the wearable device would be an example of an asynchronous interaction where data is collected at one point in time and then interpreted later on. The next term is telehealth. And the broad definition of telehealth is the provision of healthcare services using technology that goes beyond the doctor-patient relationship. So an example of this would be patient education or coaching. For example, smoking cessation or weight loss using technology. And the most narrowly defined term is that of telemedicine, which specifically refers to telecommunication technologies used to provide clinical aspects of care. Usually it's synchronous, meaning real time, and there's direct communication between the physician and the patient. So as Dr. Ferdinand mentioned, during the pandemic, there was a precipitous drop in the number of ambulatory visits. And so as you can see here in this figure on the left from the Commonwealth Fund, there was an ambulatory visit deficit of nearly 60% towards the end of March. And the deficit slowly started to decrease as we reopened. The figure on the right shows that as of June, our deficit was about 11%, and the cumulative deficit in ambulatory visits since March is at 37%. So during the pandemic, we saw the rise of telemedicine. And what you can see in this figure is that by the middle of April, we reached our peak telemedicine use. And telemedicine was being used due to necessity as a substitute for inpatient visits. And as we started to open up, as you can see, is our telemedicine use started to taper off. So given the rise in telemedicine use and the continued use for telemedicine, it's important to identify barriers to adoption of telemedicine so that we can address those barriers moving forward. One of the major barriers to telemedicine adoption, especially from the perspective of the patient, is the digital divide. So the digital divide is defined as the uneven distribution of information and communication technologies in society. There are two general types of digital divide. There's first level digital divide as well as second level digital divide, which we will define on the next slide. So first level digital divide really focuses on access. Physical access, meaning the ability to obtain broadband internet, for example, or devices such as smartphones. And material access is defined as the means to maintain the use of those devices and internet, your ability to pay maintenance expenses. A few factors that contribute to material access include education level, as well as employment and socioeconomic status and social network. Many of our low-income patients actually share devices among family members. The second level digital divide really addresses usage. So internet skills, how skillful people are when using the internet, how comfortable they feel using the internet, how frequently they use the internet, as well as the complexity of the activities that they're performing on the internet. For example, shopping or browsing the web would be a low complex, not very complicated activity, whereas using the internet for classes or telemedicine would be a more complex activity. So now that we've defined the different types of digital divide, I'd like to talk about how the digital divide affects different demographic groups in the United States. And the first group are those of low socioeconomic status. So as you can see in this chart, individuals of low socioeconomic status as well as minorities reported being concerned or worried that they would not be able to pay their bills, specifically broadband bills as well as bills for cell phones. So that's getting back to material access when we talk to the digital divide. Additionally, low-income Americans who make less than $30,000, which you can see in the dark blue, were less likely to have digital devices. We see the same disparity when we look at ethnicity. So Latinos and African Americans are less likely to own devices, except when you look at smartphone ownership, the rates of ownership are similar. However, there is a caveat: Blacks and Latinos, as well as low-income Americans, are more likely to have cancellation of their plans due to cost. When we look at the second level digital divide, which again is comfort with using the internet and using technology, what we see here is that minorities, specifically Blacks and Latinos, report that they would benefit from additional training to build confidence in the utilization of different technologies, such as computers, smartphones, as well as using the internet effectively. Language is another huge obstacle. The Pew Research Center found that for individuals who said that Spanish was their preferred language, they used the internet less frequently. And additionally, there was a big difference between Latinos born in the United States and those who were born outside of the US. Those born in the US were more likely to have a smartphone as compared to Latinos born abroad. We see the disparity when we look at geography and where patients live. So those who live in rural areas are less likely to have internet as well as access to smartphones, tablets, and laptops. And when it comes to our senior patients, we see a similar trend. So seniors report using the internet less frequently than younger Americans, and they're also less likely to own a smartphone, for example, or to have home broadband internet. It's also important to note that we see similar trends when we look at gender as well as education level. When it comes to digital readiness or how comfortable women feel with using technology or the internet, they feel less comfortable than their male counterparts. So given the widespread implementation of telemedicine and our reliance on it, and the fact that, like Dr. Ferdinand said, it's likely here to stay, how do we address these barriers to make sure that we have equity as we move forward? I would like to present a real-world case that I received from one of my attendings, Dr. Neil Chokshi at the University of Pennsylvania. We had a 68-year-old non-English speaking gentleman who had high blood pressure and diabetes who presented to the hospital in April. He was COVID positive, had severe COVID pneumonia, also presented with a myocardial infarction and acute pulmonary embolus. He was managed medically and had a week-long hospitalization. He was discharged with virtual follow-up and was enrolled in a program called Penn Medicine at Home that provided virtual care. His children helped him navigate the telemedicine landscape. While he was at home, he continued to have symptoms, chest pain and shortness of breath. Given his severe COVID-19 course, it was very critical that we were able to obtain his vitals while he was at home. So let's look at this patient in a little bit more detail and how barriers to care were addressed for him. So the first issue during the peak of the pandemic was how do we provide clinical care remotely? And the way we addressed that was through telemedicine. So the University of Pennsylvania uses Blue Jeans as our telemedicine platform. The other obstacle, and remember our gentleman was a senior, was the telemedicine adoption or his readiness to use the technology. To overcome that barrier, we relied on his children. So his children were very helpful, but also the Penn Medicine at Home program had personnel who were able to walk the patient through the process of implementing telemedicine at home. The other barrier was how do we monitor his vitals at home? He didn't have a blood pressure cuff or a pulse oximeter. So through Penn Medicine at Home, he was provided a toolkit that had a blood pressure cuff and a pulse oximeter, and they were linked and integrated to our electronic medical record. For physical limitations, he had the assistance of his family and received virtual physical therapy. As we mentioned in the digital divide, language is a big problem as well, and he was not an English speaker, so it was critical to have interpreter services integrated into our telemedicine platform. And the last barrier, as Dr. Ferdinand mentioned, is that of financial barriers. And like we said, socioeconomic status is a huge issue for many of our patients. For him, he had Blue Cross Blue Shield, and CMS provided these waivers during the pandemic for parity for office visits and virtual visits. So that was very helpful. Additionally, he was provided that toolkit with the blood pressure cuff and pulse oximeter free of cost. So as you can see, this is an example of a successful case of implementation of digital health, but it did require a significant amount of resources. So moving forward with telemedicine, especially now that we have the opportunity to create a hybrid model that includes outpatient visits as well as telemedicine visits, it's important to think about what is appropriate telemedicine use. And how do we decide what appropriate telemedicine use is? This question may be helpful in helping us delineate that. What is absolutely necessary to make a diagnosis? For example, is a physical exam necessary to manage a patient or to diagnose the patient? If that's the case, then an in-person visit seems to be more appropriate. How does one choose an appropriate telemedicine platform? I think it's extremely important that it's easy to use for both the physician as well as the patient. It needs to have good functionality and it needs to be secure and HIPAA compliant. As we move forward, I think having goals is critical as well. What problem are we trying to solve with telemedicine? At first, as we saw, telemedicine was a substitute for in-person visits due to COVID. But moving forward, are we trying to increase access? Are we trying to reach vulnerable populations and achieve health equity? And how do we measure success? How do we know we're being successful with telemedicine? These are questions for discussion. I don't know if there's a 100% correct answer, but these are just some ideas. Perhaps we look at patient satisfaction, provider satisfaction, clinical outcomes. How do we measure clinical outcomes? Are we looking at better blood pressure control, better diabetes control? We talked about payment parity. How do we maintain financial viability using telemedicine? And again, how do we achieve equity? So in summary, I think we have an opportunity now to build our telemedicine platforms as an adjunct to in-person visits with health equity at the core. And in order to do that, we need to be patient-centered. The patients need to be at the center of our telemedicine implementation. We need more evidence and we need data. We need to know what works and what doesn't work, right? And not everything is going to work for every patient. And as outlined in the case that I showed, we need resources, especially if we're dealing with vulnerable populations. So many patients don't have blood pressure cuffs at home. They don't have the ability to monitor their vitals, so we need to provide them with that. Is this an opportunity to provide community centers with computers and broadband and perhaps even kiosks so that patients in vulnerable communities or rural communities have access to telemedicine? And these are just a few resources that may be helpful for patients as well as providers. The FCC Lifeline program provides reduced cost phones as well as data plans for patients who are low income. And the HRSA and the AMA have wonderful resources for providers who are trying to implement telemedicine as well. So I look forward to coming back to some of these questions in our discussion section. Thank you.
Thank you. Over the next couple of minutes, we are now going to turn our attention to some of the practical steps that cardiovascular practices took in the era of COVID-19, because there were several changes that were brought to most practices. Initially, during the pandemic, cardiovascular practices were closed. Initially, and that included all the testing that were done in the office. But during that period of time, several independent practitioners had their consultation and follow-up visit changed to telemedicine visit. And as we heard earlier about the challenges during that period of time. Office procedures were canceled, and these often included nuclear medicine procedures, echocardiogram, and treadmill testing. Ambulatory monitoring during the pandemic in our outpatient setting, because of the service that we had, we were still able to continue ambulatory monitoring because patients were mailed the device. They used it for a week, and then it was mailed back, and the data was downloaded. As far as device clinics, most inpatient or in-office device clinics, again, were closed, and most patients that had pacemakers and defibrillators were monitored remotely. During the pandemic, there were lots of changes that were made in practices, but the biggest adjustment came when it was time to prepare for reopening, because the rate limiting step in reopening for everyone was adequate PPE. And in various states, like in my state, there were requirements that you had to have a certain amount of this available before you can open. But one of the things that we discovered in terms of getting PPEs is that as independent practitioners, we were not necessarily at the top of the line. PPEs were given first to hospitals and other nursing facilities. And so this was the rate limiting step and often took the longest, because we would get supplies a small amount at a time, but again, reopening, you had to have enough in stock. And this included masks, gloves, face shields, and gowns. Interestingly, even our regular vendors that we may have gotten gloves from before, during the pandemic, it was very difficult or we were rationed. Before opening, our facility opted to have a general sanitization. A company came in, cleaned all the rooms, all the walls, all the examination tables before coming in. And because reopening would also require social distancing, we had to develop a plan that will enable us to maintain social distancing even while in the office. This was reflected in the workflow, the schedule, and the visit type, because even as we reopened, there was a combination of televisits as well as in-office visits. Prior to opening, there was also discussion around office attire. Would you need headgear? Would we wear scrubs, the mask, the gloves, so that the clothes that were worn in the office would not be taken home with you? So there was a change in attire for reopening. Signage was also very important because as part of opening, there was a redirection in terms of office flow. And so there had to be clear signs such that the patients coming in would know where they enter, where they leave, where they stand, and where they wash their hands. We opted for a staged opening, meaning we started first with procedures. And this is because there was a backlog of procedures that were not done during the stay-at-home period. So we started first with in-office procedures that included echocardiograms and nuclear stress testing. We then opted to, after 2 weeks, start with in-office visits. In terms of in-office visits, the scheduling, like I said, was different because there was a hybrid, both televisits and in-office visits. Why this became important is if you had 2 physicians working in the office, while one physician was doing telemedicine, the other physician was doing in-office visits so that there wouldn't be that increased patient flow in the office. In terms of appointment, on the day of the appointment, patients were screened prior to making the appointment, but on the day of the appointment itself, when they arrived in their car, they were again screened, and at that time, all the payment was collected before they came into the office. When patient arrived in the office, they were sanitized at the door, temperature checked, and roomed directly. Once they left the room or the visit was completed, the exit was different from the entrance, and that was to ensure a one-way flow through the office to minimize or to facilitate social distancing. Each room was sanitized between patients' visits, and again, social distancing was very important, and we maintained this in 3 different ways. 1, when patients arrived, they waited in the car before they came into the office and were roomed. Number 2, there was one directional flow, in one door, out another door, again, to minimize that. And 3, staggering the schedule of the physician. One physician doing telemedicine, another doing patient care, and vice versa. We found this very helpful. Once the practice was opened, testing became of importance because we were backlogged, and we started first with testing. But nuclear stress testing, we only did the pharmacologic stress first test. If this was abnormal, the patient was then brought back for the rest images. Rest echocardiograms were done, electrocardiograms were done. There were no exercise stress testing or stress echoes done. Ambulatory monitoring continued because they could still be mailed to the patient due to the mail-in service that we have. Device remains being remotely monitored. So overall, in thinking about reopening, the bottom line is to continue to provide evidence-based cardiovascular care in the outpatient setting in an environment that is safe for not only the patients, but also the employees, while maintaining social distancing and maintaining good hand hygiene. Thank you.
Thank you so much, Dr. Ferdinand, for the opportunity to join this discussion today. So I just wanted to speak to the remote patient monitoring, but from the standpoint of highlighting the importance of culturally congruent health coaching, a terminology that was coined by my colleague, Dr. Priscilla Pimo. We'll hear some more about that. I do want to share my important disclosure. I'm founder and chief scientific officer of AccuHealth Technologies, and this is a company that came out of Morehouse School of Medicine based on a patent that led to the discovery and some of the work that I will present today. So this is going to be essentially a quick demo of the platform called Health 360X. It includes a mobile app, a website, and a web platform, as well as a coach portal. You'll see in subsequent slides how these different components interact to give the patient an experience of remote monitoring. One of the key things, again, we're thankful for having software engineers and architects, design architects, technology architects that have worked with us. This program, this platform actually started work back in 2012 after we received the patent, and has continued to be improved, especially with our most recent engagement with Attire Health, and you'll get to see their contributions. So it is very driven by some of the feedback we get from our patients. I should say here that about 450 patients, mostly African Americans, have used this to monitor their health through work we've done with Morehouse School of Medicine, Morehouse Healthcare, Grady Health System, as well as actually community participants in a church community called Big Bethel AME Church. Due to the short amount of time, I won't be able to share a lot of those actual detailed protocols, but welcome to review some of our publications for that. So there is a big emphasis on data security here, because in the beginning, we learned, again, with the majority African-American patients, diabetics with heart disease, and we found there was a lot of hesitance in getting some of their data on the internet. So we really spent a good bit of time in engaging on the security aspects of putting data online. And so this is a software from the patient side that can be downloaded on Google Play or the App Store. You just type in Health 360X mobile, and you can register and learn about some of the security features and begin to self-monitor your health. These are the kinds of activities that individuals can track: blood pressure, blood glucose, weight and BMI, cholesterol, physical activity, as well as hemoglobin A1C, and also medications. This happens to be, I can put my stuff on here because, you know, with HIPAA, I used to put my mom's stuff because she was real good at using this stuff, but now I just have my stuff displayed. Basically, this is me. So when I download the app, I'm able to, one thing I really want to track is my blood pressure. And as you can see, these are activities I can share or not. It's really entirely up to me. And so in a way, this is a remote, obviously monitoring myself as a patient. I do not have high blood pressure, disclosure, but I track it, and based on the guidelines, as you can see, whenever the systolic is over 120 or diastolic is over 80, it'll give you something, well, actually 120 or higher, it would tell you that you potentially have a problem. And so I like to look at these when my numbers are properly under 120 and definitely under 80. So that's, again, depending on what you're trying to work on and improve, this is helpful. So when I'm about to have a major conversation or presentation like this, I like to know what's the blood pressure. But, you know, obviously there are people like myself who may not have any chronic illness, but there are also a lot of patients who have lots and lots of chronic disease that they have to deal with. And there, tracking the medications is important, which is, again, what we encourage and work with patients to do. Also, opportunity to keep track of your appointments. I like this aspect of setting goals and creating action plans. And as you'll see, this is an effort that becomes very important because we really have a coaching model with this platform that's critical, we're finding, for many of our patients with chronic illness. And when you're on the platform, you have an opportunity to connect with a coach, and I'll show you how these coaches or other providers, so we have coaches as well as physicians, log on to help their patients. This is what a system would look like when the coach can be looking at this as well and have a dashboard that they can see what's going on with their patient panel. And again, remember, a patient has to permit you. So this starts out as a patient engagement platform, and the patient decides who can look at their data. And then again, from the coach portal, you can see opportunity to set goals, opportunity to send messages, opportunity to collaborate with other coaches, and then most importantly, work with your panel of patients in terms of how they're tracking and monitoring their health. And working on these goals, again, becomes a big part of the patient, the coach's job. In some of our earlier studies, we basically had patients monitored or coached, I should say, for 12 weeks, weekly performance or tracking of those patients. We had some of that funding initially from Microsoft Foundation. And after 12 weeks, they didn't have any more coaching, but we followed them out for 12 months and really found significant reductions in blood pressure, glucose, and activity, and it persisted over time. The coaches, as I said, have the opportunity to send messages, and so this becomes important when patients are maybe slacking off and not doing what they're supposed to do. These are additional innovations. Just over the past year, we had some funding from NIH to integrate with electronic medical records. So now we actually have the opportunity to bring in specific types of EMR. We are starting with some EMRs that are what we call FHIR compliant. This is a data standard that's supported by the industry, but also highlighted by the NIH. Because it keeps to the security standards of healthcare data. And the other exciting part of this as well, just this year, we have been getting information directly from connected devices, and this is going to be tested in the next few months. Right now, people have to actually enter their blood pressure data in any of the self-monitored stuff that they collect. But now with additional technology advancement, the platform is going to be able to connect with various devices and pull the data into the application, which would make compliance a lot easier. One of the things that I wanted to share on that previous slide is we have something now called remote patient monitoring, as you can see, as part of our title. And the reason that that's become critically important during COVID-19 is your ability to track those items as a physician actually has impact. There are codes now, ICD codes, for how you can bill for these services. And that's going to be important in terms of how telemedicine persists beyond COVID-19, but importantly for COVID-19, as you'll see in a few slides. These are just some of the aspects of this. As I said, this is a major effort. It is that you have to meet a lot of standards for security. Communication has to be encrypted. Data storage is encrypted. Access is really documented by logging in, and it's tracked, so we know who is in the platform. And obviously there are vulnerability testing, system monitoring, etc. So these outcomes that we have was presented by Priscilla Pemo. She's an internist and a professor of medicine at Morehouse School of Medicine. This is a major area of her research, trying to monitor and change patient behavior in practice by helping them with culturally congruent coaching. And I just encourage you, if you have a minute, to go out to that TED talk in Priscilla Pemo. As you can see, she has experienced over 1.6 million views, which is quite impressive. Over a 6-week period, she exceeded 1 million. And this again speaks to the need out there. People want to know how to get better health. What's the opportunity to have coaching support to do that? And the other thing she's learning from her research is that there's a way to actually mine the text data that people contribute to the platform. And she's really now looking at using that as significant behavior modification, social behavioral aspects of research. She's doing significant NIH work in that space. I'm going to close this out by just sharing that we're also using the platform to help engage our patients in the ABC Cardiovascular Registry. This is an important effort of the Association of Black Cardiologists that was actually put into place by past presidents like Dr. Barbara Hutchinson, as well as I.C. Fergus. The idea here is that just seeing patients one at a time, we're not getting enough information in a warehouse or a registry to help them with their care, but also help do some predictions in terms of what treatments work for which patients and how. And so this is work that was begun 3 years ago, and we are now, with the help of the doctors you see on this slide, including Dr. Barbara Hutchinson, we are participating with an NIH initiative to bring their patient information into the registry using the FHIR standards that I shared earlier, but also with them doing some coaching support using Health 360X. So we are very, very proud of these individuals and hope to have some data in 12 months. All of this effort will help. What I'm really most interested in is how can we use technology, including artificial intelligence and machine learning, to improve care everyday care of patients and do better prediction. That is obviously in the future, but we're closer now than we were. I want to acknowledge Chuka Ize from Vitera Health for the work he's done, Michael Prude, who's our data architecture as well, and obviously Priscilla Pemo and her health coaching team for just sticking with this work and moving it now to major innovation. And I thank you for your attention.
Thank you. We have a time for just a few questions. And I'm going to ask the first question to Dr. Ofili. Dr. Ofili, you were ahead of the curve with remote patient monitoring and telehealth. And we know during the pandemic, it's really flourished to be an important component of our care. what do you think is going to happen post-pandemic in terms of telehealth? You think it's going to kind of go away, or it's going to still be here? And of course, post-pandemic, who knows when that is? But
Yes.
what do you think?
Thank you so much again, Dr. Ferdinand, for allowing us to participate here. I actually think that's an excellent question. I've been on many telehealth, telemedicine panels from a technology standpoint, but also from a reimbursement standpoint. And I think the reason it, as Dr. Marisa Haynes showed us, the reason it just took off like it did was because CMS decided they were going to reimburse and removed major barriers in reimbursement. I think what will keep it alive is reimbursement. Many physicians are now doing a lot of televisits. They get reimbursed the same as if a patient was sitting in their office. But we are learning there are disparities to that, because many of our patients, when we closed down at Morehouse Healthcare, a number of them could only access on the phone. They could not get the video. So we started to encourage everybody to download the app, because then that way we can at least have some of their measurements, and then we can have a phone visit. But, you know, we would get phone visit empowered with data that they have collected. I think once patients get a hold of this and get comfortable with it, it would be huge in terms of the convenience to them. The one thing we want to keep an eye out for is the quality of the care. As we were hearing both from Dr. Hutchinson and Norris, as well as yourself, Dr. Ferdinand, the quality of care is critical. And if people are rushing through and just doing tele and checking stuff off, patients are not going to get the quality of care they deserve. So we got to keep our eyes open for that as well.
Thank you very much for your wonderful talk and all the work you've done in this area. Dr. Haynes, you talked about one of the insurers apparently gifts the patients blood pressure cuffs, signal monitors. I think that's wonderful. Do you think this is something that's going to be more widely available, where people can get access to tools? Because not only is it beneficial, but it helps us as clinicians take care of them.
Yes, I think so. And I think it's extremely important for the patients to have those tools so that they're able to monitor at least their vitals. And I think we all have that experience from our own clinics and conducting telemedicine ourselves. There are a number of grants that are now available to provide those resources to individuals who are from vulnerable communities, such as FCC grant that I mentioned before. But I think it's critical. We need to decide, what do we need in order to do telemedicine well, and when is telemedicine appropriate? So yes, I think so. I think if the patients have the equipment that they need, that could be a game changer as well.
Dr. Hutchinson, you are a practicing clinician. You have a practice in Chesapeake, Maryland. One of the questions that arises, what about our staff? It's difficult for staff now with the schools not being opened in terms of childcare, and also just being able to keep staff at a level where we can service our patients with many of the cutbacks that we've had in patient flow and patient care. And I'm going to ask you a follow-up question. One person sent in from the chat the idea of using the Kansas City Cardiomyopathy Questionnaire, which is a quality of life symptomatic questionnaire that patients can do even digitally, and give us some assessment of where they are with their heart failure signs and symptoms. And it has been shown to be related to hospitalization. So 2 questions, if you can do them really quickly. One is, how do you keep your staff? And the second is using questionnaires or some sort of idea of getting a sense of where patients are.
Great, thank you. Well, first of all, in terms of the staff, I've been fortunate that I have had staff for over 15 to 20 years, and most of them have older children, and so they do not have young children. I actually have one, and that one person, we made arrangement where they could work certain days from home. So we accommodated them. The second question with regard to the questionnaire, I think that's a great idea. And we've actually included some questionnaires in our pre-visit information that patient gets at home. In addition to the insurance information, a lot of those questionnaires are sent out to them ahead of the visit. So that's a great idea in terms of the congestive heart failure patients. The other thing that I wanted to mention in terms of the devices, one of the things that we do when they're making patients visits, those patients that have their own devices at home, we have them to have ready for the visit, their blood pressure, heart rate, their weight, those things, so that they're available when the physician calls.
Well, this has been a great program. I think it's another instance where the Association of Black Cardiologists has been able to bring to the community and the practicing clinician information. I'd like to thank our sponsors, Amgen and AstraZeneca, for an unrestricted educational grant. We weren't talking about any particular pharmaceutical medication or device. And those of you who do not know, the ABC is open for membership. You don't have to be Black, self-identified Black. You don't have to be even a cardiologist. You're just interested in saving the hearts of a diverse America. We are interested in anyone who wants to join the ABC to go to the abcardio.org source. We have some upcoming events, and you can go to AB Cardio and see those. You see some of the events coming up include obesity and cardiovascular disease at the NMA, which will be on Sunday, August 2nd. We have another occasion to reach out to you via webcast. Is going to be with the ABC on August 15th. And that's going to be from our access committee. We're going to deal with getting access to some newer therapies in the age of COVID-19. And we have an event that's going to follow that. That will be for those of you who are in training at the fellowship level. You can go to the AB Cardio website. We're going to have a Dr. J. Brown Best Abstract competition. It has to be done virtually, of course, on September 19th. Next slide. Will be another program for primary care practitioners that the ABC would do in conjunction with NACE, the National Association for Continuing Education. And I am so pleased to announce that we're going to have our big awards gala and fundraiser. Originally was scheduled to be in Los Angeles in person, but we're going to do it in a different way. We're going to have a global virtual experience on Saturday, October 17th. Wear your best formal clothes and be ready to celebrate the ABC for its 11th annual Spirit of the Hearts Gala. And I think that's our final slide. I'd like to thank everyone who was able to join this webcast today. And I especially like to thank our wonderful speakers, all leading ladies in medicine in their own right, for bringing information which is important, not just in the COVID-19 pandemic. We somewhat focused on that, but I think it's going to have an impact on giving excellent patient care going forward in the future. Thank you very much. I'm Dr. Ferdinand for the Association of Black Cardiologists.